Hello everyone, welcome to your calcium and parathyroid lecture as part of your endocrinology e-lectures for your themed week. This session will focus on calcium, so we'll recap on the normal calcium homeostasis, which hopefully you guys will remember from your preclinical days. Then we'll be going through the key features and causes of both hyper and hypocalcemia, as well as looking at how we'd manage both within the clinical setting. So we'll start with calcium itself. So a normal calcium level is between 2.2 and 2.6 millimoles per litre, and that equates to around 1,200 grams of actual calcium within a normal adult. 99% of that is stored within the bones, with 0.99% in the blood and the remainder being locked up within the cells. Now, calcium itself exists in three different forms. So we have a free ionized version of calcium, so calcium 2+, which is diffusible, and that's the form which is biologically active. The remainders are the two extra forms. So there's one which is bound to anions, so things like phosphate. That's diffusible, but that's not biologically active. And finally, we have a form that is bound to proteins. And when we say proteins, the one that we mainly mean is albumin. That one is also not biologically active, but that one's not diffusible either. Now, because we have this portion of calcium locked up bound to albumin, the albumin level of an individual will actually affect how much total calcium they have available to them. So there's certain patient groups who will have a low albumin level, so people who have malnutrition, people with chronic liver disease. So when we think about how much calcium somebody has available to them, we need to look at this adjusted calcium measure for the formula of which you can see on the screen here. The adjusted calcium measure asks the question of how much total calcium would this individual have if their albumin was normal. So we can compare it to another individual with normal albumin. When we think of calcium homeostasis, there are three main players that we need to consider, that being vitamin D, parathyroid hormone, as well as calcitonin. So let's deal with those each in turn now. So we have vitamin D, that's our long-term regulator of calcium. The molecule itself has a half-life of around 6 hours, and its main function is to increase the absorption of calcium from the intestine. So as I'm sure you know, you can ingest vitamin D, so your supplements, things like that, or naturally occurring within foods. But you can also synthesize it within the body from a cholesterol precursor, the one that we have up here at the top of this flowchart. And UV light catalyzes that reaction of this cholesterol precursor down to vitamin D3. Then in the liver, that is changed, that's formed to calcidiol, which is this 25-hydroxyvitamin D that we have here. Still, this calcidiol isn't very metabolically active at this stage. So what must happen is that the kidney and the enzyme 1-alpha hydroxylase converts the calcidiol into calcitriol. Now, calcitriol is the one that is metabolically active. Once that's been synthesized, it's released into the bloodstream. That's where it can stimulate the intestinal epithelial cells to increase the synthesis of the cal-binding proteins, and that's what draws your calcium in from your intestine there. So you've got to think that both the liver and the kidney are involved in this synthesis of metabolically active vitamin D. So next we come to parathyroid hormone itself. So when the serum level of calcium drops, PTH hormone is released from the parathyroid glands, which sit at the back of the thyroid gland, right in the neck. And PTH hormone works in three main ways. So the first being that it increases bone resorption. So it will bind to osteoblasts, upregulate something called RANKL, so RANKL, and that stimulates the osteoclasts and increases production of osteoclasts from its precursor cells, and those osteoclasts then resorb bone and release the calcium from that bone into the bloodstream. The second function of parathyroid hormone is to increase renal reabsorption of calcium, so it will upregulate certain channels within the distal convoluted tubule, and that will increase the resorption of calcium into the blood from the urine. This, as a byproduct, will also increase excretion of phosphate. Then finally, parathyroid hormone will increase synthesis of calcitriol. So from the previous slide, that last stage of activation of the vitamin D molecule, which is done in the kidneys, parathyroid hormone will upregulate that 1-alpha hydroxylase enzyme that we learned about in the previous slide, and that will increase intestinal absorption of calcium through the actions of calcitriol. Okay, so our final molecule that we need to consider is calcitonin. So this is released in response to a raised calcium level. It's released from the thyroid gland, so it's the parafollicular cells within the thyroid gland itself. And calcitonin works by inhibiting osteoclasts, so it would reduce bone resorption and reduce the amount of calcium released back into the bloodstream. Calcitonin itself has quite a less significant role in the calcium homeostasis than PTH, so the one that we'll mainly focus on moving forward is PTH rather than calcitonin. So what happens when all of these delicate mechanisms go wrong? So we'll start with hypercalcemia, so that's when the calcium is too high, and we generally diagnose hypercalcemia in somebody with an adjusted calcium level of above 2.6 millimoles per litre. So the way that how hypercalcemia would present, we remember using this aid memoir, which is bones, stones, groans, and psychic moans. And some people add in thrones as well, so as you can see in the diagram to the right. So stones represents things like hypercalcemic stones, usually within the renal tract. So patients can get symptoms of those, things like renal colic. Bones represents things like osteoporosis, so increased osteolysis. So if those osteoclasts are working in overdrive, increased bone resorption, you're left with reduced mineral density of your bones. That leads to osteoporosis, and you can subsequently get osteoporotic or fragility fractures. Groans represents abdominal pain. With hypercalcemia, you can get abdominal pain, you can get reduced appetite, nausea, vomiting. Constipation is a big symptom of hypercalcemia, and you can also get pancreatitis, another cause of abdominal pain. And finally, psychic moans represents that hypercalcemia can cause depression, can cause confusion, hallucinations, and in severe cases even coma or reduced level of consciousness. There are other more vague symptoms which hypercalcemia can present with, things like muscle weakness, malaise, a generally feeling off, hyporeflexia as well. And the thrones, which you can see in the image, represents polyuria, polydipsia, which can sometimes present with hypercalcemia, and that can present as a symptom of nephrogenic diabetes insipidus, which can sometimes be caused by hypercalcemia. So moving to the causes of hypercalcemia, so 90% of all cases of hypercalcemia are either caused by a malignancy or by hyperparathyroidism, usually primary hyperparathyroidism, the types of which we'll break down after. The 10% left are the much rarer causes, so those are things like sarcoidosis, TB, things like thyrotoxicosis or pheochromocytoma, or medications. So some medications can lead to hypercalcemia, and the ones I'd like you to remember, if possible, are the thiazide diuretics. They can sometimes cause hypercalcemia. And also you can imagine vitamin D supplementation. If you have too much of that, then actually it can lead to a hypercalcemia. So let's see each of those causes of hypercalcemia in turn. So we said that malignancy can cause hypercalcemia, and that can cause that in two ways. So the main one, 80% of the hypercalcemia caused by malignancy are caused by endocrinologically active cancers. So these are cancers that produce a molecule called PTH-related peptide. So that's a peptide that is very similar to the PTH molecule, so it can stimulate the same receptors. So it can work in pretty much the same way as parathyroid hormone would. So that will create hyperparathyroidism, essentially. So that will increase your levels of calcium. The other cause is cancers that have metastasis to bone. Those metastases being there will increase osteolysis and will in turn release the calcium that is usually locked up within that bone that the metastasis has settled into. Okay, so our second main cause of hypercalcemia was hyperparathyroidism, of which there are 3 types, which we need to be aware of. So our first type is primary hyperparathyroidism. So primary is when the excess of parathyroid hormone is coming directly from one of the parathyroid glands, usually a parathyroid adenoma. So that's an active benign cancer which chucks out lots of parathyroid hormone. That parathyroid hormone can work in exactly the same way as it usually does. So what would happen is we get a high PTH level as well as a high calcium level. It's activating all that bone resorption, it's increasing our amount of metabolically active vitamin D, so we end up with a high serum calcium level. Our second type of hyperparathyroidism is secondary hyperparathyroidism. This type of hyperparathyroidism occurs within the setting of chronically low calcium. So usually patients with CKD, as their kidneys aren't functioning correctly, they won't be able to produce that metabolically active vitamin D molecule, won't be able to increase the resorption of calcium that we usually lose within the urine. So for those reasons, patients with CKD end up with a chronically low calcium. In response, the parathyroid glands will ramp up the production of PTH in response to that low serum calcium. Despite this, the serum calcium level remains low if it's not doing enough, or may just creep up to normal if that PTH ramp up in production is doing its job. But as you can imagine, what you'd see is a high PTH or a low normal calcium. Now with time, a secondary hyperparathyroidism will change to a tertiary hyperparathyroidism. So that's when the patient's physiology has been stuck in this secondary hyperparathyroidism setting for so long that actually the parathyroid glands become basically autonomous, stop listening to signals. So even if that calcium level gets to the normal level, they don't stop. So they remain in that ramped up production setting, and actually it goes the other way. So you end up with a high calcium level rather than that normal calcium level we saw within the secondary hyperparathyroidism setting. So we now know what causes hypercalcemia, we know how it presents, but how do we treat it? What do we do about it? So in severe cases, but when patients are symptomatic of their hypercalcemia or their level of calcium is above 3.5 millimoles per litre, we have to do a few things. So we have to correct any dehydration. So it's basically trying to dilute that level of calcium within the bloodstream. And how do we do that? We do that by giving IV fluids. So we'd usually give normal saline, so 0.9% sodium chloride. And you can give that relatively quickly. So it will depend on trust guidelines, but depending on the level of calcium and how symptomatic the patient is, you can give that fluid quite quickly. The second thing we'll need to do is give some bisphosphonates. So those bisphosphonates work by inhibiting osteoclast activity. So they prevent further resorption of calcium, try and prevent further increases in that calcium level. And the bisphosphonates that we'd usually give in the setting of hypercalcemia are disodium permethrinate or zoledronic acid. In the longer term, our management will depend on the cause of our hypercalcemia. So if I think if it's a malignancy that's been causing the hypercalcemia, we'll need to try and treat the malignancy if that is possible. So surgery, chemotherapy, radiotherapy are usual options for treating any malignancy if possible. If a hypercalcemia is caused by primary hyperparathyroidism, if it's caused by one of those adenomas, can we chop it out? Do we have the option of performing surgery? There are some role for something called cinecalcet. So these are calcium mimetics, basically. So they try and trick the body into thinking there's more calcium than there is to try and reduce production of parathyroid hormone. So there's some role for the calcium mimetics and cinecalcet, in secondary hyperparathyroidism, but it will depend on the cause. Okay, so now we move on to hypocalcemia. So that's somebody with a low calcium level, and that's diagnosed in somebody with an adjusted calcium level of below 2.2 millimoles per litre. So how would somebody with low calcium present? So unfortunately, there's no easy aid memoir this time, but they have symptoms of perioral paresthesia, so that's numbness around the mouth, and they get this sign called carpopedal spasm. So that's flexing of the wrist and the fingers, and the fingers will draw together in response, so like this diagram at the bottom right. For people with hypocalcemia, there's a couple of eponymous signs that I'd like you to remember. So there's Chvostek's sign, so that is twitching of the mouth or facial muscles in response to tapping the facial nerve over the parotid, as you can see in the top right image. So that's due to excitation of the facial nerve due to our low level of calcium, and it's the twitching of the muscles or the corner of the mouth which is a positive sign. Next is Troisier's sign. So this is a way of eliciting that carpopedal spasm that we mentioned just a moment ago. So Troisier's sign is shown in the diagram in the bottom right. That's when you inflate a blood pressure cuff around the patient's arm as you would to manually measure blood pressure. But by doing this, you will cause or elicit carpopedal spasm in the same arm. And that is Troisier's sign, so eliciting carpopedal spasm on inflation of a blood pressure cuff. More severe presentations can include seizure, can be as bad as coma, and on an ECG with patients with hypocalcemia, you can get a prolonged QT interval, which in extremis can lead to arrhythmias. So we'll move on to our causes of hypocalcemia. So the main one is vitamin D deficiency. So that can be nutritional or in conditions like rickets, things like that. So any vitamin D deficiency can lead to a hypocalcemia. Especially common in Britain where there's not much sun, people aren't outside as much. Majority of individuals are likely to be vitamin D deficient. Our other causes, so altered PTH homeostasis, so either reduced secretion of PTH or a resistance to PTH. So it's important here to mention that hypomagnesemia can alter the effects of our PTH molecule and lead to a hypocalcemia. So individuals can be treated for their hypocalcemia and they don't seem to be responding, but actually we need to check the magnesium because we can give people as much calcium as we want, but if their magnesium remains low, then actually it would be unlikely to work. And finally, if an individual has no PTH at all, so either through parathyroid or agenesis, so things like de George's syndrome, parathyroid destruction, so surgery or radiotherapy can destroy the parathyroid glands, or autoimmune disorders, that will also lead to an element of hypocalcemia. Okay, so how are we going to treat somebody with hypocalcemia? So it will tend to depend on the symptoms of an individual with hypocalcemia. So somebody with severe symptoms, somebody who is an inpatient, we can treat with 10 milliliters of 10% calcium gluconate. So that's given IV, usually as an infusion over around 30 minutes. That can be repeated, so you can give multiple doses of that calcium gluconate to bring up those calcium levels. However, if you can give a bit of a slower infusion if you'd like, so things like over 4 hours, just to try and keep that level at a normal level. For somebody with milder symptoms, so somebody in the community, or somebody with persistent hypocalcemia after an infusion of calcium gluconate, you can give them oral calcium supplements with or without vitamin D replacement. So you may have seen some patients on the wards on things like calcium, D3, things like that. Those will contain calcium as well as some vitamin D within the same tablet. So that's it from me. I hope that's been useful for you, and I hope you enjoy the rest of your endocrine lectures as part of your themed week. Thank you very much.